let us take up the obstetrics part. The gynae part has already been covered. Obstetrics is again equally important. So, question number 1. 32-year-old female came to gynae OPD fasting wanting MTP. She is having 2 live issues. Now she presented with 8 weeks amenorrhea. She told it that it was a condom failure. She is willing for a copper T insertion. She is taken for suction evacuation in family planning operation theatre, and while doctor was doing suction evacuation, suction cannula went inside. So uterine perforation was suspected. What will be your line of management? Complete the procedure because doctor doing the MTP and the suction cannula went inside. What will you do? Complete the procedure, stop the procedure and keep her under observation. Take consent, take her for laparoscopy and laparotomy. Stop procedure and put her on antibiotics. So in this case, stop and take her for laparoscopy, and while you're doing laparoscopy, okay, you can do rest of the curettage, taking out the suction cannula. With the curette you can do it, but under laparoscopic guidance. So with laparoscopy you can stitch the perforation site. So that will be the correct answer. Now, you know, nowadays there is new MTP Amendment Act. Okay. Nowadays there is new MTP Amendment Act. Now MTP limit, upper limit has been increased to MTP can be done up to 24 weeks. And if the MTP is less than 20 weeks, then only one doctor opinion is required. If you want to do MTP between 20 to 24 weeks, 2 doctor opinion is needed. 2 doctor opinion is needed. So this was the question which was asked in the exam. 2 doctor opinion needed when it is MTP between 20 to 24 weeks. Fine. So what was the question latest which was asked? When you are doing MTP, 2 doctor opinion is needed between 20 to 24 weeks. Okay. Next. This is again an FMG exam question. Which of the following is not indicated in first trimester abortion? What is MVA? Manual vacuum aspiration. Manual vacuum aspiration, where the electricity facility is not there. There it can be used. Okay. DNC. This is also first trimester MTP. Mifepristone and misoprostol. This is also first trimester MTP. Now, ethacridine is second trimester MTP and it is no longer used. For a second trimester MTP, what we are doing is we are using prostaglandins. That is prostaglandin E1 tablet, which is called as misoprostol. Misoprostol by the vaginal route. Misoprostol by the vaginal route, or we are giving prostaglandin F2 alpha injection intramuscular. So nowadays for a second trimester MTP, that too very indicated if it is congenitally malformed fetus, okay, we are doing it. For some special indications for a second trimester MTP, routinely it is not being done. So ethacridine was an old method for second trimester MTP. It's not for first trimester MTP. Every time we keep on discussing about PIH, postpartum hemorrhage, etc. But the questions are being asked from abortions, MTP as well. That is why I am starting the obstetrics test and discussion with these questions. Now this is again an important question. Medical abortion is being done with mifepristone 200, methotrexate? No. Mifepristone and methotrexate? No. Mifepristone 200 milligram, misoprostol 800 milligram after vaginal. So the correct answer nowadays is, so what is being done? Just a minute. Let me explain. You give mifepristone 200 milligrams oral. Mifepristone is anti-progesterone. After a gap of 48 hours, tablet misoprostol 800 micrograms intravaginal. This is now preferred. This is being done when 7 to 9 weeks MTP is being done. Okay. The older one was mifepristone 200 followed by 400 micrograms misoprostol. This is oral. Nowadays, intravaginal is being preferred. Most probably, if weeks of pregnancy is mentioned, or then that would have been a better answer, because we get the questions from the students. Maybe there is additional statement about period of gestation as well. So, misoprostol is a prostaglandin analog. It can cause gastritis and vomiting. Okay. So, that is why intravaginal for local action is being preferred nowadays. Now, 28-year-old female came to gynae OPD with history of 2 months amenorrhea, and she has accidental exposure to radiation. Yes. Is it MTP? Is it chorionic villus sampling? Is it ultrasound? Is it continuation of pregnancy? If there is accidental exposure to radiation, friends, accidental exposure to radiation will be just one X-ray. It will not be 20 X-rays. So, in that case, you will not advise her for MTP. You will do continuation of pregnancy in this question. So, you have to be very, very clear in such questions. Very clear. They don't want the answer as MTP. So, they create a question the way the answer they want to set in. This has been discussed plenty of times, and this is the correct answer. Now, which of the following uterine anomaly, this I have already discussed, cause ectopic pregnancy, unilateral dysmenorrhea, and worst reproductive outcome? Unicornuate. So, I am glad that you remember the answer. Name the type of uterine anomaly. So, I want to boost up your morale. That's why I repeated this question. Okay. Now, an intern conducts the delivery. Immediately after delivery, mother experiences breathlessness, hypotension, tachycardia, and she collapses. Per vaginum examination, there is no excessive bleeding. Yes. When, just a minute, if it is PPH, the tachycardia, hypotension is being explained. But why there will be breathlessness, and when there is no excessive blood loss, postpartum hemorrhage cannot be the answer. Number 2, DIC does not fit into this category. DIC occurs when there is abruptio, septic abortion, okay, that kind of thing, which is not there in this question. Then, uterine inversion will be a shock out of proportion of blood loss. This kind of statement is also not written in the question. So, this is not acute inversion. This is amniotic fluid embolism, where either in the question it is written as unexplained shock, then it is amniotic fluid embolism. amniotic fluid embolism. Or in this question, if it is written as there is shock after delivery which is out of proportion of blood loss. Out of proportion means they are asking about neurogenic shock. When uterus is out, the pedicles are stretched. So that is not so much of blood loss, but it is neurogenic. Nerves get stimulated. So then your answer in that case will be acute inversion of uterus. If a lady delivers a child, there is excessive bleeding and she is collapsing, then it is postpartum hemorrhage. So 3 different questions. PPH, acute inversion they have asked. Now what is new? They want to ask. The new thing is amniotic fluid embolism they want to ask. So this is the exact way that they can ask you a clinical question. 28-year-old Primi gravida delivered a baby, placenta is intact. First, I discussed about MTP. Now, I am taking up complications of third stage of labor, where I mentioned about 3 answers. When to mark PPH, when to mark acute inversion of uterus, and when to mark amniotic fluid embolism. Now, another question for your practice. 28-year-old Primi gravida delivered a baby, placenta is intact, and nurse forcibly extract the placenta. Which complication is likely to take place? This December 2019 was wonderful exam where there were nearly 50 questions from Obs and Gynae. 50. And those students who have done Obs and Gynae so well, perfectly, all were cleared. Okay. Many of them has been selected and they are cleared their NEET PG and doing PG in India. Okay. So that was a very, very good exam. Of course, that huge we cannot expect इतने सारे questions आएंगे, but definitely जितने भी आए आपको सब करके आने हैं. करके तो हम आते हैं, correctly करके आने हैं. That is important. Okay. So, what is the answer? If the nurse forcibly extract the placenta, what complication can occur? They are giving you hint. Ki students, now at least write the correct answer. Now we are giving you hint, forcibly extract the placenta. Placenta will not come out, uterus will come out. That is acute inversion of uterus. Now tell me, what will be the most common cause of death in such a situation? It will be hemorrhagic shock. Death will be because of hemorrhagic shock. Initially, what type of shock appears is neurogenic shock. Initially, it will be neurogenic shock, but cause of death will be hemorrhagic shock. That is the difference or beauty in the question. Okay. Now, what is the most common cause for acute inversion of uterus? What is the most common cause for acute inversion of uterus? It is mismanaged third stage of labor. Delivery of placenta is what? Third stage of labor. So if you are not managing properly, she will develop acute inversion, which is a rare complication, but it can happen. Now, a lady has delivered the child and you're trying to deliver the placenta but fail. What is the most common problem you suspect? You try to deliver the placenta by controlled contraction method, but you fail. What is the most likely complication that has happened? Adherent placenta. That is, placenta accreta, where the placental channels has invaded the myometrium and there is no plane of cleavage. In that case, you have to shift the patient to OT and try to perform manual removal of placenta under GA. But again it fails. So what is your management is hysterectomy. So that is placenta accreta and the management will be hysterectomy. 29-year-old known case of preeclampsia presented with 35 weeks plus 5 days. There is a history of seizure, that is convulsions with headache, blurring of vision. On examination, BP is 160 by 100, cervix 3 centimeters dilated, 50% effaced. What is the next line of management? There is a history of seizures. That means it is eclampsia. Okay. So it is eclampsia. Why it is not epilepsy? Because blood pressure is given high and preeclampsia already written in the question. Okay, so it is eclampsia. Now, what is your next line of management? Tocolytic and wait, steroids and deliver at 37, LSCS, magnesium sulfate, antihypertensive and terminate the pregnancy. Eclampsia means delivery. Steroid and deliver at 37 का मतलब क्या है? You are extending for 10 days. Can you extend? In 10 days, she can have 100 convulsions and she can die. Okay? Because conservative management is for preeclampsia. What we are waiting for? We are waiting for lung maturity, fetal lung maturity. But when eclampsia is already occurred, that means there is so much of hypoxia to the mother's brain that she had thrown fit. So much of hypoxia for the baby. Now, what is the cause of this convulsion? Cause of this convulsion is the fetus because there is a faulty placenta. Okay. So, there is hypoxia to the brain. So, that is why the baby has to be out, irrespective of lung maturity. You can't wait because priority is the safety of the mother. Baby is always the second priority. So, it is give magnesium sulfate to treat convulsions and add antihypertensive. Antihypertensive of choice is labetalol. If needed, you can add up nifedipine. Okay, then terminate pregnancy. I am not saying you do cesarean. You have to do assessment. If she is already gone into active labor, you can accelerate labor by oxytocin or doing ARM. If cervix is closed, you don't have to waste time for induction of labor, do cesarean section. That is how you are going to plan the management. Always when there is convulsion, termination has to be done. But no way that you stop magnesium sulfate or you do not start magnesium sulfate and jump onto cesarean. Cesarean के बाद भी postpartum eclampsia हो जाएगा. She can die of aspiration. She can die of hypoxia. So that is why magnesium sulfate has to be given. Antihypertensive has to be given. And plan the delivery as early as possible. That is what is the best management. 28-year-old female, primi gravida 39 weeks, admitted with labor pains, BP 120 by 70 normal, uterus term, contractions are mild, fetal heart rate is normal, cervix is 4 centimeters dilated, vortex presentation -1 station. 4 hours later, contractions are just little bit increased and cervix is just 1 centimeters dilated. In 4 hours, she should have at least 3 centimeters dilatation occurred. So it is slow progress of labor actually. Membranes have ruptured spontaneously. It is a clear liquor. So they don't want your answer as cesarean. That is why they have written clear liquor. They have not written blood stained or meconium stained liquor. So they don't want your answer as cesarean. So don't you think just marking as cesarean. They have written membranes have ruptured spontaneously, fetal membranes. That means surgical induction or augmentation has already been done. Artificial rupture of membranes already been done. It is clear liker. So will you start oxytocin when membranes have ruptured? No. ARM will accelerate labor because it is a slow progress. Now, are you going to wait to reassess after 4 hours? No. You have to reassess and check now. This may be occipito-posterior, which is a slow progress of labor. To this extent, clinical question will be asked for you or not, I don't know. But you have to judge the question. That is what is an idea. That you know 1 centimeter dilatation occurs in 1 hour. So at least she should have reached to 3 centimeters more. It should have reached 7 or 8 centimeters. That means there is a slow progress. Contractions were mild and little bit it has increased. But there is no fetal distress, no PIH. Okay, just let me finish. Then once the doctor was examining, fetal membranes ruptured and it is a clear liquor. So that means they don't want your answer as cesarean. They don't want oxytocin because you've already done. Either you do surgical induction or you do medical induction. Once surgical has already occurred, you will not jump on to medical. दो induction नहीं करते usually. Either surgical or medical. So you have to reassess right now for occipito-posterior because descent and rotation and delivery will take time. Clinical question is just added up to create a sense of attempting the question correctly. Okay? How to read the question. Does not matter if by chance this question you have marked it wrong. Doesn't matter. This is a practice session for you. Okay? We don't want to increase because surgical induction will already increase the contractions now. But you have to assess, is it why the progress was slow? Is it occipito-posterior? Occipito-posterior is a slow progress. Usually presentations are anterior, LOA or ROA. That is what. So you have to assess. This is what is a partogram, WHO modified, where there is number 1, that is maternal information. Number 2 is fetal well-being, where you check fetal heart rate. Can you see? This is the fetal heart rate we have to plot like this. Then there is fetal membranes. Then third part is labor progress. Labor progress is contractions and descent, uterine contractions and descent of fetal head, cervical dilatation. 4 is IV fluids and any medication given. Oxytocin has been given or pain relief has been given, you have to mention. And number 5 is maternal well-being, where you check the blood pressure, pulse rate, temperature, urine output. So this is a complete assessment for progress of labor, maternal information, fetal well-being, labor progress, IV fluids and maternal well-being. So this is how progress of labor partogram has been done, and plotting starts from 4 centimeters of cervical dilatation. Active line, alert line and action line. Identify the type of the grip. What is this maneuver? Where you apply the fundal grip, lateral grip, pelvic grip, pollic grip. So this is lateral grip and this maneuver is called as Leopold's maneuver. This is a question from FMG exam. You just have a look at this maneuver. First grip is being applied, that is called as fundal grip. Second grip is being applied, that is called as lateral grip. Third grip is being applied, that is called as pollic grip. Fourth grip is being applied, that is called as pelvic grip. When you apply these grip to decide lie and presentation, when you apply this grip to describe lie and presentation, this is called as Leopold's maneuver. This is called as Leopold's maneuver. Fine. So you should know all the 4 grips. Now, 35-year-old lady, history of bleeding per vaginum, gravida 3, para 2, L2, abortions 0. She has 34 weeks, no pain abdomen and doesn't have any ultrasound report. Vitals are stable. Fetal heart rate is 130, uterus relaxed. What is your management? Send her for ultrasound? No. Injection Finargan, call her in ANC. She has history of bleeding. Will you send her home? No. Shift her to OT? No. Admit her and do conservative management because this might be placenta previa. Stabilize your patient first. Let the bleeding stop. So admit her and keep her under observation. This type of management is called as McAfee-Johnson's management. McAfee-Johnson's management has been asked in FMG exam. That is conservative management for placenta previa. McAfee-Johnson's management is conservative management for placenta previa. Bleeding patient you never send for ultrasound. What do you gain? Doesn't matter, stabilize her first na. Vital stable, but she's been bleeding. If it is a central placenta previa, by the time you're sending for an ultrasound, she can have bout of bleeding. But history of bleeding means she has come up with a history of bleeding. Is it written at present there is no bleeding? No. So we have to take the first line important. It is conservative management. Admit her, bed rest, arrange blood, send investigations, give steroids for lung maturity and do pulse, blood pressure, fetal heart rate monitoring. That is conservative management, McAfee and Johnson's. And when the condition of the patient is stabilized, bleeding has stopped, all investigation normal, you can get an ultrasound done, check the placenta and discharge the patient. That is what is a management and that is being done in the hospitals. Not just patient आया भगाओ ultrasound कराओ. पेशेंट जब आता है प्रेजेंटिंग कंप्लेंट उसकी हिस्ट्री ही बोलते हैं. हिस्ट्री का मतलब पास्ट नहीं है. हिस्ट्री का मतलब शी इज गिविंग यू कि आई हैव स्टार्टेड विथ ब्लीडिंग एंड शी इज प्रेजेंटली कंटिन्यूइंग. डू नॉट गेट कंफ्यूज्ड. History means she is coming up and telling her complaints. Is it written that she has a past history of bleeding? No. Please see, if it is a confusion, that is what I am here for, telling you the correct answer. See, answers in the exam cannot be according to what we want. It is according to the examiner and the answer key. So take it as I am your answer key at present. So admit her and do the expectant management and it is written in the question in this slide. Bed rest, stabilize her first, consent, arrange, steroids and stabilize. 35-year-old, she is admitted with PIH, severe pain abdomen. It is tender uterus, tachycardia, cervix is 4 centimeters dilated, blood stained liquor. She has been prepared for LSCS. Why? Because there is fetal bradycardia. This is fetal distress. Fetal bradycardia. She has been prepared for LSCS. All the steps are done. What is this type of uterus? It is covellar uterus. Covellar uterus. What is the diagnosis of this case? PIH with abruptio placentae with fetal distress. PIH with abruptio placentae with fetal distress. Because normal fetal heart rate is 110 to 160. It is less than 110. So, cesarean section is done not for abruptio but for fetal distress. And you find this kind of uterus. So, complete the cesarean, give oxytocin deliver placenta by controlled contraction, hysterectomy is not needed. In covalent uterus, just finish off the cesarean and close the abdomen. If we get a bruise, do we excise the bruise? There will be color changes and in few weeks it will resolve. So that is what, it is a clot in the uterus. So it will resolve. Nothing to be done. Question of FMG exam. WHO maternal deaths is within 6 weeks after delivery is maternal death. Maternal death is within 42 days of termination of pregnancy. Instrument used for ARM. It is Cocker's forceps. This is artificial rupture of membranes. Artificial rupture of membranes. So it is Cocker's artery forceps. What are the indications for ARM? Post-dated pregnancy, PIH, abruptio placentae. These are the important indications for doing ARM. And aim is to accelerate the labor. What is ARM doing? It will accelerate the labor. It will accelerate the labor. In these cases, there is a chance of fetal loss. So you want to deliver as early as possible. So it is a surgical method of induction or augmentation. Surgical method. Medical method is oxytocin. Surgical method is ARM with Cocker's artery forceps. This is the instrument and this is how it looks like. It can be used in gynae as a clamp. While you're doing hysterectomy, you can apply this as a clamp. In obstetrics, it is used for ARM. Artificial rupture of membranes. Primigravida comes to antenatal checkup at 22 weeks. This is a smart series question. Let me check how many of you can mark it correctly. She has perceived fetal movements, normal ANC checkup. She has a feeling of giddiness, blackouts while getting up from the bed, no difficulty in breathing, pulse rate normal, BP normal, hemoglobin normal, proteins negative in urine. She is taking iron folic acid regularly. What will be your advice? Send CBC, salt restricted diet, urgent ECG. Salute. Good question, good answer. This is normal. You have to think she is just having superior vena cava syndrome, or when she is lying supine, the inferior vena cava get compressed. So she is advised to lie down in the left lateral position. Remember, in obs and gynae, in obstetrics, in a pregnant lady, we advise her as long as possible lie down in left lateral position so as to have a adequate blood supply to herself and her baby. That is the answer. Why salt restricted diet? She is not hypertensive. Why ECG? She is not heart disease patient. Why CBC when hemoglobin is normal? Think out by ruling out the options. 19-year-old girl, this we have already discussed. This is H. molar pregnancy. So what is your management? Suction, evacuation. Lady visits, presents with high blood pressure and 34 weeks. What is the next step? You are going to check urine proteins by the urine dipstick method. High blood pressure, no proteinuria, that is gestational hypertension. For preeclampsia, proteinuria is not mandatory, but we are doing urine proteins. Now, high blood pressure and end organ damage. This is how you differentiate a mild preeclampsia from a severe preeclampsia. That is rise in creatinine, low platelets and elevated liver enzymes with a visual or cerebral symptoms. Labetalol is alpha plus beta blocker. Drug of choice for eclampsia, magnesium sulfate. Now I want to make you happy by discussing these single liners which you are most interested or always interested. Antidote of magnesium sulfate, calcium gluconate. Safe anti-epileptic in pregnancy, levetiracetam. Then lamotrigine. Anti-epileptic drug with maximum teratogenic effect, sodium valproate. Which vitamin is added with phenytoin? Folic acid. First sign of magnesium sulfate toxicity, disappearance of knee jerk. Safe therapeutic level of magnesium sulfate, 4 to 7 milliequivalents per liter. So if you get this pattern, most of you will be very happy in your exams. But we have to revise single liners, clinical questions, image based questions and concept based question always. Jitna hum kar sakte hain, that we have to go. Okay, so that's why I'm discussing single liners as well in between. Lady presented with vaginal breech delivery. This is for your practice only. Which statement is false? Continuous fetal heart monitoring is done. Correct. Breech delivery is to be done in hospital where emergency facility is available. True. Done by the experienced person because he or she will have the confidence and the experience of delivering breech vaginal delivery, doing certain maneuvers. This is true. Breech identified for the first time in delivery is a contraindication for normal delivery. No. This is the false statement. So good that you have been able to solve the INI CET pattern question as well. A baby born very pale to the mother who had APH. Name the type of placenta responsible. Filamentous insertion of placenta. Name the condition. Condition is vasa previa, where the blood is fetal in origin. Blood is fetal in origin. Name the type of placenta. This is filamentous insertion of placenta. And what is this type of placenta? Succenturita lobe of placenta. This is responsible for secondary PPH. And this is responsible for vasa previa. That is a type of APH, antepartum hemorrhage. Now, what is secondary PPH? Definition is an important question. It is PPH occurring after 24 hours of delivery, within 12 weeks after delivery. That is secondary PPH. What is the most common cause for secondary PPH? Is retained bits of placenta. Retained bits of placenta. Most common cause for secondary PPH, retained bits of placenta. two doctor opinion is needed. It is 20 to 24 weeks. And between 13 to 20, one doctor opinion is needed. Which is incorrect about magnesium sulfate? It has anticonvulsant effect. This is true. But simultaneously lowers the BP. This is wrong. It does not lower the BP. Is it antihypertensive? No. It is anti-eclamptic. Anti-eclamptic. Does it work in any other epilepsy? No. It quietens the uterine activity. True. Maintenance dose is 24 hours after delivery. True. It is excreted by kidneys. True. So wrong answer is A. It does not has antihypertensive effect. Next. 25-year-old para 1L1 delivered 12 weeks back. History of continuous bleeding. This history of DNC. Most likely explanation for this bleeding. Patient has PPH? No. After 12 weeks, there will not be PPH. Patient has developed DIC. DIC will be after the delivery, not after 3 months. Patient has developed gestational trophoblastic neoplasia. Is it normal lochia? Normal lochia is till 3 weeks. Normal lochia is till 21 days after delivery. So it is gestational trophoblastic neoplasia. Medical student is being questioned on a female structure homologous to male vas deferens. What is this structure? This is Gartner's duct. Glands of skin is homologous with prostate gland. Bartholin gland is homologous with Cooper's gland. Cooper's gland is in males. Prostate gland is in males. Apophoron is a remnant of Wolffian duct. Apophoron is remnant of Wolffian duct. And Gartner's duct is vas deferens in males. Alright, if you want, you can click this and you can just revise this so that your structure of origin is very clear to you. So you can read it and you can write down the notes from there. 27-year-old has recent abdominal cramps, vaginal bleeding, 3 months amenorrhea, and on examination cervix is open and products of conception are felt and there is bleeding. What is this? This is inevitable abortion where products have not expelled. If the products are expelled, it will be incomplete abortion. Okay. So the sequence of abortion is there is cramps and bleeding, but cervix is closed. When products of conception are hanging out, then it is incomplete. This is inevitable. Cervix closed is threatened. So there is always a one question in FMG exam, either from threatened abortion, inevitable or incomplete. Most of the time it is threatened or it is inevitable. So cervix closed is threatened, cervix open is inevitable, products start expelling and size of the uterus less is incomplete. 32-year-old lady, 38 weeks, admitted with painless bout of bleeding yesterday. Hemoglobin 10.5, BP normal, uterus relaxed, fetal head is unengaged and floating, but fetal heart rate is regular. What is your next line of management? She has bleeding and 38 weeks has already occurred. Head is free floating. We cannot wait for next bout of blood. But this question might be confusing and it is raising controversial level. Although the answer is cesarean in this question, because why? Because the type of placenta previa is not mentioned, and in FMG exam there is always a clear cut hint in the question. In this question, it is not clear what type of placenta previa is it. Is it a minor degree or a major degree? Whenever they have asked question in FMG, they have written central placenta previa, bleeding profusely, 37 weeks, so your answer is cesarean. 34 weeks, dead fetus, central placenta previa, answer is cesarean. So that kind of question. So this is raising the controversy. So there is always a hint in FMG questions. Just make it a point. 35-year-old G3P2L0, no live baby, 37 weeks, bleeding profusely, central placenta previa at 32 weeks. Will you repeat ultrasound? No. Any ultrasound done after 28 weeks is a third trimester. Mark your answer accordingly. So what is your answer in this case? Caesarean section. So this is a question of FMG exam. So I just wanted to tell you that in your exam question will be in this pattern, where clear cut hint in the question. Next, 28-year-old labor pains G2P1L1, 36 weeks with previous LSCS with breech presentation, no scar tenderness, cervix is 5 centimeters dilated, buttocks swelled. What is your management? Because if you do any manipulation, uterus will rupture. Previous LSCS with malpresentation in the present pregnancy is an elective cesarean. You will not give trial of labor. This is somebody has done a blunder and patient की किस्मत अच्छी है कि रप्चर नहीं हुआ, बट अगर आप वेट एंड वॉच करोगे तो पक्का उसको मरा ही दोगे, इन द सेंस कि रप्चर यूट्रस करा ही दोगे. तो previous LSCS with malpresentation is always your answer as cesarean. Just to tell you that, I have added this question. Clearing your concepts in this session, because you have December month for revision. November will be gone for other subjects. December will be revision. Unless until we give you a correct way to prepare. How will you prepare in short duration of time? That is what is an idea. Malpresentation, scarred uterus, cesarean. Bleeding placenta previa, cesarean. Especially if it is major degree mentioned. Okay. If history of bleeding, vital stable, conservative management. Less than 37 weeks, conservative management. Unexplained shock after delivery, amniotic fluid embolism. Bleeding, not more, but patient is in shock, acute inversion of uterus. Tender uterus, pregnant lady, third trimester bleeding, abruptio placentae. So that's how you are supposed to grasp the answers. Next. Your question exam. So it is marginal placenta previa. These are the 4 types of placenta previa. Identify the image. Placenta is in upper segment and there is a retroplacental clot. This is abruptio placentae. So 2022 exam they have asked abruptio, 23 exam they have asked placenta previa. Can normal delivery done in abruptio? Yes. Name the placenta responsible for APH filamentous insertion we have discussed. Name the condition vasa previa we have already covered up. 25-year-old female with 2 months amenorrhea per speculum examination shows the sign of pregnancy. This is Hager's sign of pregnancy, 6 to 10 weeks it is positive. So uterus is felt enlarged and cervix feels empty. Uterus is enlarged and soft and cervix feels empty. This is Hager's sign. If division of the fertilized ovum occurs between 9 to 12 days after fertilization, it is monoamniotic monochorionic. Division occurring within 72 hours, diamniotic dichorionic. Division occurring between 4th and 8th day, diamniotic monochorionic. Division occurring after 8th day, monoamniotic monochorionic. Division occurring after 13th day, conjoined twins. So from the topic of twins, this is the most commonly asked question on the monozygotic twins. Okay, on the monozygotic twins. Mortality is high in which type of twins? Monochorionic, which is monozygotic. Chorionicity scan is done between 10 to 14 weeks. Twin pregnancy is best diagnosed with 10 to 12 weeks by ultrasound. Most common fetal complication of twins, prematurity. Monozygotic twins can be differentiated by fingerprints. So, not just clinical questions and image-based questions. I am discussing the previous FMG exam questions, concept-based questions, clinical as well as single liners. So, मैंने अपनी साइड से कुछ छोड़ा ही नहीं है. आपकी साइड है, हम भी नहीं छोड़ेंगे. Very well. ठीक है, this one you are able to memorize the question which has been asked in your FMG exam. There's an example. So you can't blame me. ये नहीं कराया, वो नहीं कराया, सब कराया. तुमको कितना करना है वो देखना है. So all are true about dizygotic twins except. So single placenta is a feature of monozygotic twins. It's a feature of monozygotic twins. This is very, very important. Let's just finish it off and then the class is over. So all are done to treat breast engorgement except cabergoline is not given for breast engorgement. What is breast engorgement? Milk has get collected in the breast, it needs to be expressed. So this is a painful condition. You give analgesics, hot fermentation, express the breast milk, oxytocin if needed. Cabergoline will suppress the breast milk. Suppress the breast milk. So cabergoline is given when there is dead baby. Then you can think of giving cabergoline, but not as a treatment for breast engorgement. All are the drugs to treat atonic PPH except mifepristone. Mifepristone we are using as an emergency contraceptive or it is used as abortifacient. It is used as emergency contraceptive. It is used as abortifacient. It is used in cases of fibroid uterus. but it is not used in case of postpartum hemorrhage. What is the first line drug to prevent and to treat PPH? Answer is oxytocin. What is the first line drug for active management of third stage of labor? Answer is oxytocin. Which hormone causes milk ejection reflex? Oxytocin. The hormone that causes milk ejection reflex is again oxytocin. Dose for elemental iron and folic acid. It is 60 milligram of elemental iron and 0.5 milligram of folic acid. Lady having 2-year-old child has come for antenatal checkup in the second trimester. What do you give? TT or TD? Formula used to calculate EDD is Niglis formula. Hadlock formula and Johnson's formula is to calculate the expected weight of the fetus. Hadlock formula by ultrasound, Johnson's formula by clinically. So these two formulas are used to calculate the expected weight of the fetus by ultrasound and by clinical method. Testosterone is secreted by Leydig cells. Which of the following is not included in active management of third stage of labor? Delivery of placenta by controlled contraction, true. Injection oxytocin, true. Uterine massage, not done. Late cord clamping is done. So uterine massage is a management of atonic PPH. Uterine massage is the management for atonic PPH. Lady delivered a shock, this I have already covered up. What is the management of third stage PPH? Manual removal of placenta under GA in operation theatre. Most common cause for secondary PPH, we have done all this. Active management for third stage of labor is oxytocin, delayed cord clamping and controlled contraction delivery of placenta. What is this manual? Manual removal of placenta. This is done for third stage postpartum hemorrhage. This is done for third stage postpartum hemorrhage. Identify the type of placenta responsible for secondary PPH. It is succinturita lobe. Anal sphincter tear is which degree perineal tear? Third degree perineal tear. First degree is mucosa and skin tear. Second degree is mucosa, muscle and skin tear. Third degree is anal sphincter tear. Fourth degree is anal canal. tier. Type of pelvis, android. That is called as male type of pelvis, heart-shaped pelvis, and deep transverse arrest occurs because the transverse diameter is shortened. Which type of pelvis deep transverse arrest occurs? Android. One answer, it is android pelvis. In case of diagnosis of occipito-posterior, appropriate management is wait for the progress of labor. Which diameter is being measured in this image? This is diagonal conjugate, which you can measure clinically. Diagonal conjugate you can measure clinically. Correct sequence of lochia. Lochia rubra, serosa, alba. Duration of lochia 21 days or 3 weeks. Primigravida given birth to a male child without any issue for the mother or infant. After how many hours? That means there is no maternal complication, no fetal. It is within 1 hour. A woman was referred to PHC with prolonged labor. She is now been taken for LSCS in fetal distress. What is the correct position the nurse is going to keep the patient on the OT table is? Supine position with a wedge under right hip to give a left tilt so that inferior vena cava compression can be avoided. This is what is inferior vena cava compression. What is obstetric audit? Includes all. Preterm labor it will not include. So this is what is audit. Maternal deaths, infant deaths, severe morbidity, instrumental delivery, cesarean section, all this is maternal audit. Oxytocin is contraindicated in abnormal lie. All of the following are triple test markers for Downs except estradiol is not a marker. These are the markers for Downs. In 21 and trisomy 18, alpha fetoproteins is decreased, beta HCG rises, estriol decreases. Trisomy 18, all are decreased. What is the fourth marker for quadruple test? Inhibin. That is elevated. Name the type of placenta. मैंने क्वेश्चन क्या बोला? What is this condition? Pre-gestational diabetes. What is this? Caudal regression syndrome. That is very, very characteristic of diabetes. That is very, very characteristic of diabetes. In gestational diabetes, which is developing in the second half of pregnancy, there is no congenital anomalies. Congenital anomalies are seen. Congenital anomalies are seen in diabetes patient who are now pregnant. But gestational diabetes is developing after pregnancy, means pregnancy has gone beyond 24-28 weeks, then gestational diabetes develop because of increased insulin resistance. So congenital anomalies do not occur in gestational diabetes. But this is pre-gestational diabetes, sacral agenesis. Phenytoin is different. Cutoff value for plasma glucose in glucose challenge test is 140. Identify the maneuver. This is what case? A shoulder dystocia. Shoulder dystocia is a complication of macrosomia. Macrosomia means a baby whose weight is above 4 kg and it is delivering normal vaginally. Macrosomia is an indication for elective cesarean section. But if the lady comes and started delivering, then shoulder dystocia will occur. What is this maneuver this nurse is doing? This is a Mac-Roberts maneuver in order to facilitate the delivery of the baby, because baby has got stuck up at the level of shoulders. So this is Mac-Roberts maneuver. It's all given in your undergraduate textbook, Datta. 35-year-old lady presented at 20 weeks. An ultrasound shows funneling of cervix. Cervical length is 21 mm. What is this? This is cervical incompetence. And how do you treat cervical incompetence in pregnancy is McDonald stitch. That is, tighten the cervix at the level of internal os. If you give Cerviprime gel misoprostol tablet, it will abort the pregnancy. We see that in this case, she already has 2 abortions. We have to save this pregnancy. So we apply McDonald stitch, put her on bed rest, and tocolytics are needed, not steroids. Tocolytics are uterine relaxants. What is the first line tocolytic agent? Nifedipine. First line tocolytic agent is nifedipine. That is the best first line tocolytic agent. What are tocolytic agent do? They prevent the preterm labor pains because they are uterine relaxants. So in this case, apart from McDonald stitch, you have to do bed rest and you have to give tocolytic agents to this lady. But funneling of cervix has already taken place in this case. Oxytocin in heart disease patient can be given intramuscularly to prevent postpartum hemorrhage. But oxytocin is never given in abnormal lie like transverse lie. If you give oxytocin, she will go into labor. We don't want abnormal lie patient to go into labor. And exactly these 4 options came, or there was some other option? Because students are the ones who are telling us the options. If I look, these are the correct options, then answer will be abnormal lie. We have to rule out and then mark the answer. Next. Identify the type of presentation. Such questions are expected. This is a broad presentation because occiput is posterior, so it is not vertex. Mentum is posterior, it is not face. It is this part which is broad. This part will be felt. The supraorbital ridges and the frontal bone. So it is a broad presentation. What is the engaging diameter in broad? Mento-vertical 14 centimeter. That is the largest diameter of fetal skull, and the management is cesarean section. Now, this is vertex presentation. This is face presentation. This is brow presentation. This part is the brow. This part is the face, and the anterior fontanelle part is the vertex. What is the mode of delivery in brow presentation? Cesarean section. You will not get questions in continuation. This is just to discuss the topic. What is the management of this case? Cesarean section. What is this condition called as? Neglected shoulder presentation. Neglected shoulder presentation means transverse lie. transverse lie in labor pains. You do not know that there may be thinning of the lower segment. So we have to do a cesarean section in any case of malpresentation. What is recommended as a folic acid with neural tube defects? 4 mg. Which of the following is not contraindication for normal vaginal delivery? Not. Previous macrosomia. अभी थोड़ी है मैक्रोसोमिया, प्रीवियस था ना. Previous to LSCS is elective cesarean section. Previous classical is elective cesarean. Contracted pelvis. See the question in your exam and you are marking it wrong. PG तो ठीक कर रहे हो, MCI गलत कर रहे हो. इसमें हार्ड क्या है बताओ? Maximum amniotic fluid is seen at oligohydramnios is seen in renal agenesis. Drug not contraindicated in pregnancy. Propyl thiouracil. Match the column will not be asked in your exam, but it is for practice. Let us do. Breech presentation, Prague's, shoulder dystocia, Macroberts, normal delivery, Ridgen, lion presentation, Leopold's. जब टाइप कर रही थी तो बी पहले टाइप हो गया, ए पीछे चला गया, बट आंसर तो लिखा है ना. Which is not true in obstructed labor? Bandel's ring is visible, true. Hematuria, fetal distress is true. Bandel's ring is not physiological. It is pathological retraction ring. What happens? Upper uterine segment contracts. Lower uterine segment dilates. Suppose if it is a transverse lie, it will not deliver. So there is a ring formation occurs at the junction of upper and lower segment. We can see with our eyes perabdominally. This is pathological retraction ring, which is Bandel's ring. Any obstructed labor, always management is cesarean section. Always. No destructive operation, no delivery, no oxytocin. It's always cesarean. Modified Bishop score includes all except uterine contractions is not there. It is cervical dilatation, cervical length, consistency of cervix, position of cervix and station of presenting part. This is Bishop score. Cervical dilatation, cervical length, consistency of cervix, position of cervix and station of presenting part. G2, Gravida 2 has second stage of labor more than 1 hour. Cervix is fully dilated, pelvis adequate, vertex at +2 station. Mother is exhausted. It cannot be forceps because it is unrotated head. So it is vacuum extraction. Female with previous cesarean section, prolonged labor. She is hypotensive. Fetal heart rate cannot be heard. Fetal parts palpable superficially. Uterine rupture. So it is cesarean section has to be done. 25-year-old primary gravida on lithium. So which anomaly is suspected? Abstains anomaly. 26-year-old mechanical valve on warfarin. What will you do? Replace warfarin with heparin. All of the following cases for vaginal delivery allowed except. Rest all normal delivery can be done. But monoamniotic, monochorionic twins, mortality is high. So we want to do a planned cesarean section for them. Just for your practice. Instrument, very correct. This is to hold the uterine angles. This is to hold the uterine angles. Green Armitage here is applied. Okay. Muscles attached to perineal body are all except iliococcygeus is not attached. It is pubococcygeus which is attached. Maneuver done for breech with extended legs. Pinards. This is Pinard's maneuver. This is Burn-Marshall technique for after coming head. This is Morrissey-Smiley-Viet technique. This is Lofset's maneuver. Lofset's maneuver is breech with extended arms. Pinard's maneuver is breech with extended legs. Burn-Marshall is after coming head of breech. Morrissey-Smiley-Viet technique is after coming head of breech. So this you have to remember if by chance they can ask you image based question. 30-year-old female, what do you see in this case? OHSS, ovarian hyperstimulation syndrome. What is this image of Doppler showing? Reversal of end diastolic blood flow in the Doppler. It's a case of PIH and IUGR, intrauterine growth restriction. So this image shows reversal of end diastolic blood flow. What is the reason of abdominal pain? Oxytocin. Because it is acting on the breast and on the uterus. Which of the following is an indication? So surgical management. So indication for surgery will be ectopic mass more than 4 centimeter. Patient wants to continue wrong, beta HCG less than 1000, then this will be medical management possible. Unruptured ectopic pregnancy, you can go for a medical management. What is this image? Leash-Wilkinson cannula. This is normal HSG. Milk ejection reflex, oxytocin. And serial beta HCG is been done for molar pregnancy. This was a very final revision from my side. Of course, if the time allows, we will take, not this big elaborated session. This was just to open up your eyes and give you a boosting confidence that you know the subject. Among all the other major subjects, this is the subject where you can master and you can have a good weightage of correct answers in any exam you are going to write. The first exam you will be writing is FMG. That is your beginning of journey. And your journey will continue in your boosting or creating your career in life. Okay. So all the best from my side.